Hi, this is Dr. Nick from the ECG Academy, and we're going to continue our discussion of sinus rhythms. This is an ECG that I came up with from my files. And before you approach it, let's just review what you're supposed to be looking for. You want to look at your P waves, your QRS complexes, and your T waves. Look at the P wave appearance. Make sure that it looks like a normal P wave. Measure the PR interval and make sure you're in the right ballpark between 120 and 200 milliseconds. Calculate the rate and examine the P-wave vectors. Make sure that it's upright in 1 and AVF. And if you can't see a P-wave, then lead 2 is probably the best place to look for one. And then make sure that it's the only P-wave and make sure there aren't any other atrial events going on. So we'll look at this cardiogram right here. If you look at lead 2, you see a very generous P-wave here, a QRS complex that looks pretty large, and we'll get into how to diagnose abnormally high voltage on the 12-lead course. And then the T wave looks appropriate. The QT interval seems reasonable. It's less than 1/2 the R to R interval. All right, so and the P wave is up in 1 and it's up in AVF. That tells you that the P wave vector is down and to the left, so everything looks good. One last thing to look at is the rate. So if we look at this QRS, it's on a heavy line. And so we'll count off 300, 150, 100, 75, 60, 50. So if the heart rate is 50 beats per minute, and the P waves appear to be coming from the sinus node, then we have a diagnosis of sinus bradycardia. So sinus bradycardia, by definition, is a heart rate less than 60 beats per minute originating from the sinus node. So the P wave looks normal. It's rising from the normal spot, and it looks like it's traveling in the normal direction. So this is an example of sinus bradycardia. It's a fairly common arrhythmia, one of the most common that we see. It can be due to any number of abnormalities, and we'll talk about that in the section on sinus node dysfunction. But as an introduction to arrhythmias, this is how you diagnose sinus bradycardia. Okay, so now let's look at the next ECG. Now here we have an example of another ECG. Remember, look at the forest first. If you scan across that rhythm strip, you can see the R to R intervals look to be quite regular if you glance across. And now let's find the rate. It doesn't really matter what sequence you do this in, as long as you try to be consistent when you approach every ECG so that you don't miss anything. Don't jump around and figure out rhythm, then rate, then STs, then voltage. It should be regimented in your own style, and you'll get more practice reading more difficult tracings if you subscribe to my chalk talks. This QRS complex lands on a heavy line, so it's 300, 150, 100, and somewhere between 100 and 150. Well, here's a clue. I'm going to give you a sort of a Dr. Nick Pearl. If your QRS complex is not clearly on a heavy line and you're having a little trouble interpolating it and figuring out exactly what it is, instead of measuring the number of milliseconds and dividing it into 60,000, examine 2 R to R intervals and see what the heart rate would be, and then just multiply it by 2. So here's what I'm talking about. Start with this one, ignore this QRS complex, and just what would the rate be if it's here? So we count off 300, 150, 100, 75, 60. So if these 2 QRS complexes were there, the rate would be 60, but since there's one in the middle, that gives you a rate of 120. Look at that, how easy. So the key is to just measure off 2 R to R intervals, calculate what the rate would be, and then double it. So that's a quick and easy way to get a more accurate measurement of heart rate when your QRS complex kind of lands in between 2 heavy lines. We've established as a heart rate of 120. There's clearly a nice, healthy, juicy-looking P wave in front of every QRS complex. The PR interval looks to be physiologic. It's probably about 160 milliseconds, just eyeballing it. Is it up in 1? It's a little bit up. It's certainly up in AVF. So it would appear to be a sinus rhythm, but greater than 100 beats per minute. And so this is known as sinus tachycardia. So sinus tachycardia arises from the sinus node, but by definition, it's a heart rate of greater than 100 beats per minute. And so it's easy to diagnose sinus tachycardia, just like sinus bradycardia. So now let's take a look at the next example. Now this is a rhythm strip that came off of a telemetry unit. The first thing you should look at is what lead you're recording. And this says lead 2. You can't always trust it, but if the nurse puts the wires on using the correct colors on the right limbs, then it should be accurate. So scanning across, you see a regular QRS complex. If you look at the trees, you can see that the QRS is marched through pretty nicely. You can use calipers, but I think eyeballing it is just as easy. The problem is that you do have a little bit of noise here. There's a bit of a high frequency jiggle all throughout this electrocardiogram in both leads. You have lead 1 and you have a V lead. We're not sure where this V lead is located. The R wave looks a little tall for it to be V1. It's more likely V4, V5, something like that. You never know in a telemetry unit where they're going to stick that V lead. But it's this high frequency noise that kind of makes it a little bit harder to recognize what's going on. But you have to kind of look past it. That's the key. Ignore the noise and look in front of each QRS complex for a signal that looks consistent. Because if you have a P wave, then you should be able to get a sense that it's there. It may look a little different from beat to beat because this noise is superimposed on top of the P wave. If you have a P wave like that and you superimpose a bunch of noise on it, then you're going to wind up with something that doesn't look as smooth and as normal as you like. But look at that, sort of towards the end of the tracing, the noise kind of goes away, and then you're left with a very smooth-looking P wave. So we can measure that PR interval from here to here, and it looks like it measures about 160 to 180 milliseconds, still in the normal range. The QRS complex is pretty narrow. The QT interval looks reasonable. You can probably measure it, and it'll likely be at the upper limits of normal. We won't go through those calculations for this video, but you should know how to do that already. And lastly, let's examine the rate. And it's 300, 150, 100, so it's faster than 100. So even not knowing exactly what the heart rate is, we can already call this sinus tachycardia. So this is sinus tachy, or sinus tach, some people call it. The heart rate, to be exact, is probably about 110 beats per minute. So you're doing great so far, huh? It's not that hard. So let's go on to the next one. And this one looks a little bit like the first ECG. And if you'd rather look at the heart rate first, that's completely up to you. The first thing you should look at is regularity. Look at the forest, and these beats seem to be fairly equally spaced. And the heart rate is slow. I mean, I think you start to eyeball it and say, wow, that's slow. It's more than 5 boxes, so it's less than 60 beats per minute, right? It's 300, 150, 100, 75, 60. And this is 50, so it's less than 50. And 40 would be way out to here. So it's about 48 beats per minute, just below 50. So are the P waves normal? Well, they're up in 1. They're up in AVF. It looks like that's the only P wave. Here's a little clue in identifying P waves. When you look at a QRS complex, the change in voltage, in other words, the sharpness or the frequency content is very high. In other words, the voltage changes very rapidly in a very short period of time. So the slope of this signal is very high. And it's almost like, if you look at sine waves, electronic waves of electrical energy, sine waves are measured in frequency. How often do these occur? And that's related to how far apart the waves are. T waves tend to be very low in frequency. In other words, they're very gradual changing in the voltage. The slope of the T wave is actually rather low. It's not a sharp, spiky looking signal. P waves tend to have an intermediate, a little bit sharper signals, a little bit higher frequency signals in a P wave. They tend to change a little bit faster, certainly faster than a T wave, but not as fast as a QRS. So the QRS has the highest frequency component. the quickest, most rapid voltage change. P waves have less higher frequency deflections, but they're certainly faster and sharper and spikier than T waves. So what I always tell people is when you're looking for a P wave, you have to look for a sharp deflection. So in other words, T waves tend to be nice and smooth, but if there was a P wave superimposed on that T wave, then you'd wind up having a signal that kind of looks like that. A little bump, or a sharp spike, or sometimes the T wave will look like it has a bite taken out of it. That high frequency, sharp, spiky part of the signal very well may be a P wave buried in there. So I always kind of like say, when I see heart rates below 50, could there be another P wave hidden in there? And one way of looking at it is to look for the midpoint between two P waves and look right in the middle to see if you see something that looks just like that, something that looks like a sharp, spiky signal. And here in this tracing, you just don't see it. And so I think it's fair to say that this P wave in front of each beat is the only P wave, and therefore you're dealing with sinus bradycardia, or sinus brady, as we refer to it. So if this is sinus brady, it fits all the criteria. The P wave is by itself. It looks like a normal P wave, has the expected vector or down and to the left of the patient. The PR interval is normal and the rate is less than 60. All right, so we'll do one more example here. Now this is off a 12 lead, so we know it's definitely lead 2. So here again we have a situation where the QRS complexes are easy to see. They look to be fairly regular. They march on through. And where's the rate? Let's find a QRS that lands close to a heavy line, right about here. And we'll measure off 300, and it would be 150 if it's here, but it's faster than that, isn't it? It's less than 2 big boxes. It's probably about 152 beats per minute. So we're talking about 152 beats per minute. Now we're looking for P waves in front of the QRS complexes. And you'd see this positive deflection right there. And you'd think, well, is that the P wave? I wonder. Well, keep in mind that P waves usually have a flat segment in front of them. You have the P wave, and then there's a PR segment before the QRS complex. So you should see a fairly discrete P wave. Now, not always. You should be looking for a fairly discrete signal followed by sort of a flat segment before the QRS complex. And I would say that the flat part that follows this deflection kind of slopes down a little bit. And that has me bothered. It doesn't look flat to me. And the P wave really doesn't look like a P wave. It's very narrow. It's a very short upward deflection followed by sort of a slopey signal. And don't get fooled into thinking that this is sinus tachycardia, as I'll show you why. If I actually scroll this strip over and look at what happens to it after a little while, you start to see that there's actually a repeating pattern here that looks like a sawtooth. And this we'll learn in a subsequent lesson is atrial flutter. So in fact, you have an atrial rate that's actually faster than 300 beats per minute. And that's typical for atrial flutter. So don't get fooled into thinking that any upward deflection is a P wave. And this is a typical example of an ECG that might have been misread as sinus tachycardia, but in fact, it's not. All right, so keep all this in mind as you continue to practice reading ECGs. And in the next lesson, I'll show you one interesting phenomenon that occurs during sinus rhythm, and that's known as sinus arrhythmia. So for the ECG Academy, this is Dr. Nick. Thanks for watching.